Welcome to our first grand rounds of the new academic year. I'm Steve Martyr, and I'm proud to introduce our first speaker, Tom Insel, who is one of the most important authorities in American psychiatry. I first became familiar with Tom Insel's work when he was at the Yerke Center and Emory, where he was helping to develop the new area of social neuroscience and provided very pioneering work on the role of oxytocin and vasopressin in mammalian social behavior. From 2002 to 2015, he was the director of NIMH. While he was there was incredible progress in neuroscience, genomics, and understanding how the brain functions during mental illness. Tom was always able to ask the important questions, and I recall in NIMH, he wondered why psychiatry was so far behind other areas in medicine in developing new and innovative treatments. We were kind of relying on treatments for serious mental illnesses that were really decades old. And again, there was substantial progress during his years. Following his years of NIMH, he has really looked at how new technology can aid in both understanding mental illness and treating it. He recently led the mental health team at Verily. He co-founded MindStrong Health and served as an advisor on mental health to our Governor Newsom. In 2022, he co-founded Vanna Health, a startup building, a startup that was building digital versions for psychosocial care for people with serious mental illness. But in this talk, he's going to talk about a book that I read a few months ago when I heard about it in the New York Times. It's titled Healing, Our Path from Mental Health. Our Path from Mental Illness to Mental Health. And in it, Tom kind of looks back on his own work and the work of others and asks the question about why we haven't made more progress. And he finds the answer in part in the fact that we actually have had effective ways to relieve some of the suffering of people with mental illness. But our mental health care system and the incentives within that system kind of interfere with it. I see it as kind of a remarkable event in individuals being able to look back at one's career and sort of reevaluating what's really important. With that in mind, I'm very pleased to introduce you to our speaker today, Tom Insel. Go ahead, Tom.
Oh, thanks so much, Steve. What a pleasure to be here. And gosh, it's great to be the inaugural Grand Round speaker for this year, meaning that there are probably a bunch of relatively new residents or interns in the audience, I hope. At least those who can drag themselves away from today's January 6th hearing, which is, I was just watching, was just in the middle of it myself, and it's pretty extraordinary. But there'll be a chance to go back to the hearing. And in the next hour, actually more like 40 minutes, I just want to take you through some things I've been thinking about a lot. And in a way, this may be a kind of a good presentation for being the first in the series, because I'm not going to talk about a specific study or a specific scientific finding. I really want to step back and look at the broad landscape of where we've been, where we are, where we're going in mental health care, and actually talk about, and this will kind of be where I'll end up, the difference between mental health care and mental health. We tend to often equate the two, and I'm going to make the claim, and hopefully we'll end up talking about this in our conversation after, that if we really care about health, we have to think about more than just health care. So with that, and with your permission, let me share some slides. I'll go ahead and share my screen here, and hopefully you're able to see this, and I'm going to be able to walk through this pretty quickly. As Steve mentioned, this is the title of the book, Healing: Our Path from Mental Illness to Mental Health. And that book is very much, as the title suggests, my own odyssey for trying to understand a couple of problems that I couldn't figure out by myself. Before we get into that, let me just quickly provide my disclosures, of which there are many. I've spent the last 6 years in the private sector, some for-profit, some not-for-profit. And maybe it's the topic for a later conversation that we could have in another Grand Rounds presentation. But I think mental health, the mental health world is in this very interesting transition where so much of the innovation, so much of progress is actually happening in the private sector and not so much in the public sector the way it might have been in previous years. And the private sector no longer means pharma. It increasingly means techs, it means healthcare startups, it means a whole range of very creative entrepreneurial people who are trying to innovate on what we do for patients with mental illness. So I'm involved in many, many parts of that, some for profit, some not for profit. I'm not going to talk about any of them today, so I won't belabor this point, but we may want to come back to it in terms of not just what needs to be done, but who's going to do it and where it'll be done. So let's talk about the conundrum that led to the book. And it's really building on what Steve was just saying. This last 2 or 3 decades have been pretty extraordinary for progress in science, and particularly in behavioral science and in technology broadly. So there's every reason to think that we should be hopeful and excited about where we've come from. And I think it's worth pointing out, although many people in the public wouldn't agree with this, that we've got pretty effective interventions. And if you look across the range of disorders, from eating disorders to anxiety, depression, psychotic illnesses, the attentional disorders, we actually have stuff that works. Some of it's medical, some of it isn't. A lot of it is more on the psychological side. Some of it's rehabilitative. We'll come back to all these points, but it's important to understand that we have good tools. We have a lot of arrows in our quiver that we can begin to use to help people. And indeed, if you talk to people on the front lines, they'll tell you that they are helping and that more people are getting more treatment than ever, according to SAMHSA and their annual NISDA survey. And yet somehow, with the sense that individually we're really making a difference, at a population level, the numbers are all going in the wrong direction. And that's kind of what I set out to try to understand in this book, because I think given where we are in science, given where we have these interventions, given that all of us have this sense that we're effective in with what we do and more effective than ever before, why are the data at a population level telling us something very different? And let me just quickly share what I mean by population level. This is the fact that when you look at morbidity or mortality, as of 2019, even before the pandemic, neuropsychiatric disorders had really emerged as a leading source of disability or morbidity. No surprise, because they in fact start much earlier in life than most cardiovascular or oncological diseases, certainly more than most musculoskeletal disorders. These are the disorders of young people, and they're often serious and truly disabling. But if you simply think about what we mean by morbidity, which is not only prevalence, but these kinds of outcomes around disability, I think it won't surprise you to make the claim that the rates of unemployment, of homelessness, the rate of incarceration, the fact that life expectancy continues to be about 20 years shorter for those with serious mental illness, that all of these things have not improved for people with serious mental illness. But even beyond morbidity, if one looks at mortality, in spite of the fact that we have phenomenally exciting stories to tell in much of medicine, if one that just looks at suicide, you can see that there's been about a 30% increase, even a little bit more than that in 2019. It's come down a little bit in the last couple of years. Um, Not the story that we want to be telling. And if you actually broaden out that issue around mortality to include deaths of despair, which would be overdose deaths and deaths related to alcohol addiction, you can just see that even before the pandemic, we were looking at striking increases, maybe more than a doubling here in deaths of despair. And of course, the pandemic hasn't helped. We've seen a massive increase in drug overdoses in particular that are driving these numbers up. And if one looks actually, just to get some sense of the context and scale, one looks at COVID itself, where we've had by the beginning of June over 1 million deaths in the United States from COVID. You can note that those are mostly in people over 50. If one looks at, as I said before, that in mental illness, we're talking about young people, the number of deaths from COVID uh, since January of 2020, 7,420 for people under the age of 30. In that same period of time, if you look at suicide and overdose deaths, we don't have the most recent data from 2021, but if you take the 2020 numbers and you look at the aggregate numbers for 2021, we can sort of make a guesstimate that we're looking at over 90,000 deaths of despair in young people and people under the age of 34 at a time when there have been probably less than 10% of that as actual deaths from COVID. So it's important to recognize that these are not small numbers. We're looking at really something that does constitute a public health crisis. And of course, that begs the question of why. And when I was working on the book and did a lot of traveling around the country, actually around the world, asked people this question of why are we in this crisis? I got plenty of answers, which I'm putting up here, including a lot of people who said this is really about stigma. Um, my own sense is that none of these really explain the problem as we see it now. I think you never know enough. People often say we don't have enough therapists. There are actually almost, according to SAMHSA, about 700,000 people in the mental health workforce. That's relative to about 200,000 in the primary care workforce. We don't have effective treatments. Actually, I think we do. And that's a point that we need to keep remembering as we think about this crisis. We don't spend enough. Well, we're spending probably about 1.5 times what we were spending a decade ago. So the expenditures are way up, but often going in the wrong place. And I particularly dislike the term stigma. I know it's become very popular in the mental health community, but I think it's a term that uh, tends to breed a kind of passivity and victimhood. I think the real term that we want is discrimination, which is more likely to lead to action and to a discussion of civil rights and social justice, which is much more, to me, relevant to what we're going to have to face if we want to solve this crisis. So I have a different set of causes, and I think it's critical to remember there's not one thing that has led to this care crisis, and it is indeed a care crisis. It's not an epidemic in the sense of a new problem. It's an old problem that we are dealing with in a way that is really ineffective. My list, and I'll go through them very quickly and then unpack each one, is that we no longer have the capacity to deal with this either in the institutions or in the community. We don't have the safety net that we had in previous years. We don't have engagement for most of the people who need care the most. In fact, as people become more sick in cancer and heart disease and diabetes, they're more likely to be in care. Just the opposite is true in mental health. There's a problem for those who do seek care in terms of quality. And a huge issue in this field is the lack of accountability or measurement. And finally, there's a very serious issue around equity, which I'm going to spend quite a bit of time talking about. But for now, I think it is important to clarify the problem before we talk about solutions. I'm going to spend a few minutes just unpacking this problem statements, these 5 issues. Then I'm going to talk about where are the solutions, some of which will come out of, I think, the world of innovation and technology. Some of them won't. I'm going to end up by really focusing on that last bucket, the issues around equity and the need to think differently about how we address particularly those people with the most serious forms of mental illness. So let's jump in. I'll begin by unpacking the capacity question and the tremendous underinvestment that we have both in facilities as well as in community resources for people with serious mental illness. I said a moment ago, we're spending a lot of money. That's true, but we're spending it by incarcerating people. We're spending it in crisis care. What we're not spending it on are the things that actually help people with their mental health. It's really a sick care system that we built. That sick care system at one point was in the 60s and 70s largely had a state hospital focus. As all of you know, we went through the deinstitutionalization in the 80s, but even in the 70s, as you can see here, but in the blue line, but actually it was a trans-institutionalization that over the course of 80s and 90s, we really built out the criminal justice system to become the default mental health care institution. And any doubts about that, I think, are resolved by just realizing that on any given night, there are probably 10 times more people with serious mental illness in our criminal justice institutions than in any sort of public health institution, which is really an extraordinary statement and almost unique to the United States. Lack of engagement. I mentioned before, as people get sicker, they're even less likely to be in care. When you look at the numbers that we have, and these are actually numbers put together when I was still at NIMH, the best idea we have is that about 40% of people who could and should be in care are actually receiving services. The quality of care is not great. About 40% of those who get into services are getting what the NCSR originally called minimally acceptable care. And we know that with that level of care, about a third get well, a third somewhat better, and a third don't get any benefit. I call this the 40-40-33 rule. It's really the reason why when you talk to individual providers, they will tell you that they're effective and they're helping people, and they're helping people more than they ever had in the past. Generally, that's what I hear. But you have to remember they're seeing about 6% of the population in need, at least the ones who are giving higher quality care. That if we really want to begin to bend the curve at a public health sense, we've got to go way, way up this cascade and make sure that the figure of people receiving services isn't 40%, but more like 80%, and that the quality of care is going to be much, much better. In terms of quality, we got a problem. If you look at the HEDIS measures, which I know are not ideal, but they're one form of quality standards that we can look at. And you just compare mental health standards and mental health scores to what you see in cardiovascular medicine. Two things jump out. The top 3 lines are cardiovascular, bottom 3 lines are mental health. In this case, the cardiovascular measurement is persistence of beta blocker treatment for 6 months after being hospitalized for an MI. The bottom 3, the mental health, or the likelihood of a 7-day follow-up after hospital discharge. And the two things to point out are that even back in 2005, cardiovascular was doing somewhat better, irrespective of whether that's private, Medicaid, or Medicare. But what really strikes me is the second thing, which is that as cardiovascular has improved, so that on this particular measure, it's the 70 to 80, maybe even 90% level of compliance. Actually, the numbers overall for mental health have gone down, not gone up. And the overall likelihood of having a 7-day follow-up after hospital discharge, truly the sort of valley of death for a lot of patients who are leaving a mental health facility those first 7 days, we're down less than 50%. getting any sort of follow-up at all. That was in 2016. More recent numbers, in some ways, are even worse. So we've got a problem with quality. That may relate to the fact that there is not the accountability in this field that we have in so many other parts of medicine. Measurement-based care has been a sort of buzzword for over a decade in mental health, and yet it is still the exception, not the rule. Less than 20% of practitioners engage in any kind of measurement-based care. Even though we talk a lot about value-based care and the need to shift to a value-based model, if there's people aren't measuring anything that you can conclude is related to value, it's very difficult to shift to that kind of accountable system for mental health. And finally, equity. And as I said, we're going to talk about solutions for all of these, but this is the last slide and maybe the most difficult to look at in terms of what the problem statement is. We're in the middle of a long overdue reckoning about race in this country and the health disparities and social disparities, income inequality, all of those issues related to people of color. There's another lack of equity, another disparity that I think needs to be called out for those with serious mental illness, irrespective of race, although those who are both people of color and have a serious mental illness, for most of these graphs are going to represent those with double jeopardy. So there's no question that these lines are not entirely independent. But I point this out that whether one looks at life expectancy, rate of employment, the use of force by police, or the likelihood of incarceration, if people with serious mental illness, with psychotic illnesses, were a racial or ethnic group, they would be the most disenfranchised part of our population. They would be the untouchables. And I'm sharing this with you, and not because in any way I want to minimize the social injustice faced by people of color, but because as psychiatrists and as mental health professionals, this has happened on our watch. And I appreciate the reckoning we're having around race. I just want to ask you, when we begin to have this reckoning around the gross social injustice, the lack of equity for people with serious mental illness, because this is, by almost any measure you look at, the group which suffers the most in terms of all of these measures that we care about when we talk about equity. We'll hear more about that in a moment. So let's talk about solutions, because the problems are depressing enough, and I'm by nature optimistic and hopeful, and I think we're at a moment when there's lots of exciting stuff to discuss. I'll break the solutions conversation into three different areas. I'm going to talk a little bit about what we can do on innovation. Some of this will have to do with policy as well. And then I want to really focus the last few minutes on changing the conversation that we have around mental health and actually talking about mental health as something more than our current conception or construct of mental health care. So let's jump in. Problems we've just gone through: capacity, engagement, quality, accountability. There are solutions on each of these. And again, I'll go through them quickly and then we'll unpack each one. Capacity, to some extent, you fix that with money, and you fix that by building facilities, building community supports, building out the stuff, the safety net that's been missing. Engagement, there's a lot to say about that. We won't spend much time, but there's a lot of ways to begin to engage people in the way they want to be engaged, rather than building a system for payers or providers, building a system for clients, for people with mental illness is a very different system. Quality, we can talk about this in terms of training and how to coordinate care, accountability. Well, there's lots of ways to bring in measurement, and then equity will get us into the recovery conversation. Okay, let's start with investment and see where we're at. There's been an explosion of private investment, especially from private equity, but also now venture capital. This is just one example. The venture capital firm Rock Health monitors what's going into digital health broadly, and you can see huge increase during the pandemic. Lots of reasons for that, but of course, much of it was that that healthcare generally went remote, and so startups that were focused on telehealth did very well. What's probably less evident from this graph is that when you look across all these different areas for innovation, mental health in 2021 emerges as the by far largest target for investors. $5.1 billion in venture capital money last year alone for mental health startups. Some that were actually became quite large over the course of the pandemic. There are now 10 unicorns in the mental health space that most of which did not exist 5 years ago. A unicorn means that their valuation has surpassed $1 billion. I'm a little loath to point this out, but I can't resist that $5.1 billion for new companies is more than the budget of NIMH, NIDA, and NIAAA put together by a lot, especially when you consider that the NIH budgets mostly go to paying the out years of old grants, not the first year of new grants. Only about 30% of the NIH institute budget is going to new grants. So this is real money, but it is even more interesting to realize what's happening in the public sphere for health services. So just a quick sidebar here. If you follow the history of investment, of public investment in mental health care, it's been a game of hot potato largely. Obviously, before 1963, this was the domain of the states. State hospitals were where people with mental illness ended up. With the Community Mental Health Act of 1963, President Kennedy set us on a federally funded national mental health system. That's extraordinary. We've never had anything like that for cancer or heart disease, but there was all of a sudden a national network of mental health care clinics in every community, which we called catchment areas in those days. That allowed the states to move the money they had been spending in mental health care other places. They could suddenly build more jails and prisons, which is what they did beginning in the 1970s. Reagan ended that investment from the federal government, created the block grant system, that's SAMHSA. SAMHSA being created a little bit later, but certainly in that period, after the Reagan years, the community mental health was defunded largely, and Medicaid began paying out what states and counties were requesting for their mental health care. So the key thing to realize in that 1980 to 2018 period was that largely mental health became once again the domain of the states. And the federal government provided money, mostly through Medicaid, a little bit through the block grant, but the block grant was never more than $1 billion. But the leadership, the actual services and the design of mental health care was really the domain of states. And that has been continually true for the last essentially 40 years until now. And suddenly things have changed very rapidly, partly through the pandemic, even a little bit before the pandemic. SAMHSA, which has for almost since its inception had been a tiny agency. When I left the federal government in 2015, SAMHSA was a $3 billion agency, now is more than a $9 billion agency just in a very few years as the block grant has been expanded. The Center for Medicaid and Medicare Services has hugely expanded what it's going to be doing for mental health care, particularly in states like California that have provided a new waiver for how Medicaid gets used. And what's most extraordinary is the growth of a new national community behavioral health or mental health care system called the CCBHC system, which started as a pilot in 2017, 2018 in 8 states, 62 centers, expanded in 2019 and 2020 to about another 30 states, but just as very small SAMHSA generated pilot grants. And then on, what is it now, 2 weeks ago, probably the most consequential mental health bill in terms of the federal role in 40 years, or 39 years. I'm sorry, since 1963. So that's actually what, uh, almost 60 years, um, was the Bipartisan Safer Communities Act, the gun bill that was passed in the wake of the Uvalde mass shooting. And what that did, although no one has talked about this, is it considerably increased the investment in CCBHCs to $9.3 billion. So we suddenly have a massive new federal program for behavioral health. The CCBHCs provide whole person care. These aren't actually heavily used in California, but for the rest of the country, they will be a large part of how mental health care is delivered to those with serious mental illness and to those with substance abuse. It's a no wrong door, whole person care, prospective payment system that is going to be really a new era for the federal development, the federal support, investment in mental health care. So a lot to talk about there in investment. In terms of engagement, when we think about how do we engage those who are not, my claim would be ask people what they want and give them what they're asking for. When you do that, what you find out is a lot of what we have is not what people want to, a lot of what we're selling isn't what people want to buy. They're really looking increasingly for convenience and to a large extent, often for community. It's so interesting to me that the models that we have that often have people waiting weeks instead of hours for when they're in crisis simply aren't working. And why would we expect them to? I think that especially for people under the age of 25 who've grown up with Amazon Prime and same-day services, convenience trumps almost anything else they'd be looking for. We're not thinking about that. And the other thing we've learned a lot, I think, through the last couple of years is the importance of community. The Peloton model for how to engage people is something we can learn a lot about in mental health. Humanist is a company that I'm no longer involved with, but when I was, they were doing this very interesting work with UC Berkeley. They asked several thousand students, would you rather have one-on-one therapy or asynchronous group chat with 19 of your peers? 70% of the students chose asynchronous group chat. They didn't want what we had expected they would really be looking for. So there's a lot to learn here by beginning to understand what it is people are looking for. Improving quality. There, the opportunity to use data in a way that gives us real-time dashboards of what's working and what isn't. IESO Health is a fascinating company in the UK. They don't have a United States presence, but they mostly provide CBT online through either text or chat or sometimes voice. Every interaction they have between a therapist and a client gets collected through a natural language processing engine that gives real-time information about therapeutic alliance, about symptom levels, about improvement, changes in a whole range of different outcomes they care about. And that has mattered as they've gotten more data and they get their therapist. So this is using the data for the therapist, not for the patient, but for the therapist to do a better job. You can see they, in fact, have gotten better clinical results. They've now treated over 100,000 people, 500,000 hours of therapy hours. And that information, because it provides real-time feedback, a sort of closed loop system, has really led to better outcomes. This idea of measuring, it seems to me, is still one of the places which is part of this accountability factor where we really do need to up our game. It's not just that we want people to be completing a PHQ-9 or creating some version of measurement-based care. But when you think about what we care about, how people think, how they feel, how they behave, our laptops and our phones know so much more about that than we as clinicians are likely to learn by asking. And we're actually engaging people in telehealth through the very platforms that have all this information, the sensors, the ability to do face processing, even just capturing voice and speech in ways that give us deep information, objective information about how people are doing. And yet we don't collect any of that. We don't use it in trying to understand whether someone is getting better or not, whether somebody is getting close to a relapse or not. Um, there's no question the data are there that we can do this, that it does work. But Telehealth 1.0, which is what we've been doing for the last 2 years, um, really doesn't take advantage of any of that kind of information. So there's lots of opportunities for us to develop a different kind of measurement-based care. So just to summarize, I mean, if you think about those problem statements, the issues around engagement, around quality, around measurement and accountability, um, there's to me, there's no question that technology can help us. Certainly, mobile interventions, being able to deliver therapy or coaching or peer support or even crisis in a way that's democratized, that's in real time, that is convenient for people, is going to make a difference. Especially if we can go beyond just focusing on access and really think about quality. And quality is going to come out of doing a better job on training our workforce, but also doing a better job on collecting results and looking at um, what the metrics that count, coordinating care in a way that really helps, improving how we do care management. And finally, all of this um, can be empowered by getting better measures of how people think, how they feel, and how they behave. And something that we ought to be able to do through digital phenotyping in a way that doesn't necessarily have to be intrusive, can respect privacy, can give people agency, but can at least give us some objective measures. So rather than just asking people, how are you sleeping, actually have a decent measure, objective measure of sleep. And we can do that for a whole range of things that we care about in terms of getting a sense of how patients are progressing. Ideally, you want this to be a closed loop. You want to create a learning engine. We've done this brilliantly, I think, in diabetes. We ought to be able to do it in depression, PTSD, psychotic illnesses as well. So the opportunities are there. I think the tools are increasingly there. Pulling it together is still very much a challenge to create this kind of landscape. A quick thought about this, because often when I talk about technology, people are want to know about the apps, and they want to ask about privacy, and they want to ask, they really worry about surveillance and a whole range of issues which are super important. Um, my own sense about technology and its role in mental health is that we're just getting started, and it will be transformative over time. But at this point, I think probably more important than any software or hardware is what we as an industry or as a discipline can learn from the technology industry and discipline. And by that, I mean focusing on the culture of how tech companies work. And was the thing that really stunned me when I left the NIMH and went to Google. Google is, it's essentially an advertising company. And I'm not going to make any argument that that their motto, "Don't do evil," is something that they've ever lived by. But what is really stunning is how well they function internally as a company, how well, at least in the days when I was there in 2016, 2015, that they had three things that they do for every project, which we need to start learning from and instilling in what we do. One, I put together the first mental health team there, and when I did that, people said, "Well, who's doing UX?" And I said, "I don't know what you mean by UX. It's user experience. It's understanding what consumers want, understanding what your user really needs, what they want, not what they like, but what they love." We don't do that in mental health unless we want to think about our user as being the payer. We're not starting with patients or clients to really understand how do they want to get care, what care do they want, when do they want that care, where do they want to get that care. all critical questions that a UX design engineer will ask. They're very data driven. So they collect the kind of data that you see in this wheel diagram continually, and they base all of that on what they do next. Feedback is fundamental to the way that tech companies work. They are learning engines. I remember working with the search team at Google, and they said to me, at any given moment, we're doing 120 experiments on search, and we work really hard to make sure that they don't in any way complicate each other, that there's no overlap. Those experiments might last 4 hours, and they may have 10 million data points in those 4 hours. But based on what we learned from that experiment, we do something different in the afternoon than we were doing in the morning. It's a different way of thinking about how we work in the world of providing mental health care, that you use not only UX design, but you collect the data and the feedback constantly to improve what you do. And that's the way you change outcomes. So I've talked to you about investment and increasing capacity, and then we talked about all these different ways of looking at engagement, quality, and accountability. We haven't talked about equity. And in the time we have left, I want to take the next 5 minutes really to go through that part of the story. Some of it, in terms of equity, if you think about those things like the use of force by police, the incarceration piece, we'll begin to address that when we fix crisis care. And we'll begin doing that, hopefully, on Saturday, because this week is when 988 goes into effect. I've been showing this slide for 18 months, 2 years. It's fun to actually think that we're at that moment. And of course, we're completely unprepared. The federal mandate, and this is another example, the federal government now getting involved in mental health care nationally. So they are requiring by mandate of Congress that every jurisdiction by this Saturday has 988 in place. It's just the mental health care crisis line. And what it does is, if done well, it gives you someone to call, hopefully with someone to come, someplace to go. This is what that looks like in Tucson, Arizona, where Margie Balfour has built out one of the best models we have for crisis intervention. It's pretty interesting. So it's not, when you call 988, instead of 988, you're calling, instead of calling 911, you're calling someone who's basically a teletherapist. 988, it's a crisis line. They're not a dispatcher like 911. They may stay on the line for an hour. Dee Hirsch, which is your local crisis line, is able to handle something like 96% of the calls that come in. And by the way, the Dee Hirsch crisis line receiver will call you back the 24 hours later to make sure things are okay. You don't likely get that with 911. So this is a different kind of response for crisis. If they can't handle the problem, a mobile crisis team is sent out. It's not a medical surgical ambulance. It's not a police car. It's going to be likely a social worker, a nurse, maybe a peer. If they can't handle the problem, it's not going to a medical surgical emergency room or jail. It's going to a drop-off facility, crisis stabilization unit, a psych ER. Many of those are being built out in LA right now. And then there's a series of community wraparound post-crisis services that can be put in place. This is the first step that we need to get serious about over the next couple of years. Obviously, this doesn't go into place on Saturday, but Saturday is the starting line if we're beginning to build out the continuum that we'll need. It's of course not enough. We don't want a crisis system. Arguably, every time there's a crisis, we've already failed to provide the care that should have preempted the crisis. So we need to think about a different model. And that's what I want to talk about finally, which is this recovery model. I actually didn't understand recovery very well until a visit to Los Angeles. In fact, I was talking to John Sharon, who was until recently the director of the county mental health agency in LA. And he was saying, if you want to understand recovery, you have to think about the 3 Ps. I was thinking like Prozac and Paxil. And John said, no, 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 no. It's people, it's place, and it's purpose. That those three P's are really critical, that it's not about just looking at symptoms. If you really get serious about this, you've got to really think about what we mean by healthcare, because currently people, place, and purpose are not part of healthcare, and yet they're essential for the recovery journey. Now, we had already done a little bit of this at NIMH with a coordinated specialty care model for people with first episode psychosis. That's what FEP is. And you can see that that was already focusing on what you need for recovery. And it was clear that it wasn't one thing, it was a bundle of care. And all of those things came with this kind of culture of shared decision making, with a lot of focus on building skills and making a commitment, not only that was comprehensive, but that was continuous for at least a year. And when you do that, the results are great. We know that from New York, where we've seen really great outcomes for young people with first episode psychosis. And you can see this in the work from Lisa Dixon and others, that very high rates of engaging in school and work, low rates of rehospitalization, global functioning measures are all much, much improved. But of course, that's for first episode psychosis. Maybe 100,000 kids a year have a first episode. We're talking about 14 million people with serious mental illness. And for that, we need to really revisit what we do in the mental health care system more broadly. It's a little bit like the coordinated specialty care world, but in that it's comprehensive, it's a bundle of different services. And some of those, the dark blue, are the same actually, but many of them putting in clubhouses, ACT teams focused on housing, particularly supportive housing. Those are the way to achieve these three Ps with, again, the same sort of cultural um, rendition that you see with coordinated specialty care of shared decision making, family engagement, a whole range uh, of what I'll call a different way of engaging people long term with serious mental illness. And engagement is the big challenge. That's why you need ACT teams. That's why you need peers. That's why you need to think about the long term investment that you can make here. Clubhouses are particularly helpful for that. And yet, Los Angeles doesn't have a clubhouse. In fact, LA doesn't have many of the things that are on this figure that still need to be built out. It's also important to think about prevention, which we could call the fourth P. And I think one of the places where we continue to fail in the mental health sick care system, we'll call it, our mental sick care system, is that it's so still focused on crisis. The good news is that California, of all states, has made a real commitment through this new $4.4 billion Child and Youth Behavioral Health Initiative. And I won't spend a lot of time on this. We can talk about it in conversation if you want. But this really is the first state to make such a massive commitment to going upstream and making sure that not only kids, but families get the support they need, particularly through building out a new workforce that will be working with schools and working with now a new navigation system, a portal that is just being developed or has just gone out for an RFP. I'll finish up just by saying that, I think, as I said at the very beginning, part of what I came to understand in writing the book, and I think we all need to think a little bit more about, is that if we care about mental health, we have to think well beyond what we currently consider mental health care. That mental health care or clinical care generally maybe accounts for 10% of our outcomes overall. And what accounts for outcomes in general medicine, but in mental health as well, are lots of other factors. Some we sometimes call social determinants. I'm not sure that's a good term, but it's a lot about those three Ps. It's where you live, it's who you live with, it's how you live. Those are the things that really matter for recovery. Those are the things that matter for health and for health outcomes. The irony here is that we spend about $3.8 trillion on that 10% sliver on the clinical care part, the clinics, the emergency rooms, the medication. On the other pieces, the 70% related to social factors, basically it's philanthropy. You've got, um, I'm on the board of Fountain House in New York, and we hold bake sales just to keep the doors open. It's really, it's a pretty scrappy and very underfunded world that is critical for recovery, and yet it's not yet covered by health care dollars. We need to think that through better. We need to revisit that. So I'll finish up by just saying that we started with this conundrum that with all this progress, our outcomes are no better. And I ended up with the book thinking that part of the reason is that we're so focused on healthcare and not on people, place, and purpose. That, yeah, it's probably fair to say that the problem we're facing, problems like psychotic illnesses, serious mental illness, they are indeed medical problems, right? They are problems that should be considered brain disorders in which, they deserve the same research, the same reimbursement, the same rigor as any other medical problem. But the solutions are so much more than medical. The solutions are social, they're environmental, they're even political. And we have to think through all of those other issues and ultimately, I think, redefine what we mean by healthcare to include those three Ps. So what I've told you, we have a crisis in mental health as well as in mental health care. The solutions are lack of capacity, engagement, quality, accountability, and equity. I think the path to get better outcomes, better results is going to go through these three Ps: people, place, and purpose. And the problems are indeed medical, but the solutions are much broader. They're social, they're environmental, they're political. What I'm really calling for is a kind of recovery model, not simply a medical model for dealing with the whole range of issues that people face when they have a serious mental illness. So that's my story. If you want to read much more about it, there's the book. If you haven't subscribed to Mindsight News, the proceeds of the book were used to support this nonprofit journalism effort. It's free. It's a digital publication out every day with information about recovery-oriented and solution-focused journalism on all things mental health. And Vanna Health is a new company I've just founded as executive chair that is creating a startup, creating all of these psychosocial supports, the ACT teams, clubhouses, enhanced care management, not in California, but in several other states, working with local community partners. So love to hear your thoughts about all of this. I'll stop sharing my screen. I'll turn this back over to Jonathan and Steve.
Yeah, thank you so much, Dr. Insel. Really appreciate that presentation and the time you have to answer some questions. I had a question just to get us started off, and if anyone in the audience has questions, feel free to use the Q&A button. You brought up a lot of concepts like measurement-based care or focusing on the user experience that I don't think are really reflected in medical education or in residency or fellowship training as much. I think starting to be, but perhaps could be a lot more. Are there any other ideas that you'd have for changes you'd like to see to medical education to help prepare for kind of the future that you're envisioning?
Yeah, I think I used to say that your medical education is sort of like is just the admission card. It gets you started. Your education about how to become a healer goes throughout your whole career. You just so you're not going to get all that much except maybe some of the vocabulary and the ticket through your education. But what I really mean by that is that you learn from your patients. And my advice to residency training directors is get rid of a lot of that didactic stuff. And the stuff everything you really need to know, residents are going to learn from patients by learning to listen and learning to observe, and also listen for what isn't said, which is probably the hardest thing when you're starting off, because it takes time and it takes some skills. So my advice about training is getting those skills, getting the observational and listening skills. It's like the parallel to physical diagnosis. This is sort of psychological diagnosis, but it is very much a skill that has to be learned.
Thank you. We have some questions coming in from the audience. One person asks, as you look globally, are there other countries that have been more successful in improving mental health care? And can you highlight examples of approaches that seem to work in other nations?
Yeah, I mean, there's no Camelot for this. There's no place where I can say everybody with schizophrenia is working, but there are plenty of places where they do far, far better than the United States. I like to say that in mental health, all countries are developing countries, but the places that are probably most developed are, they're Trieste and Verona in Italy have just done beautiful things over decades to get people with serious mental illness into the workforce, get them, through school. Places in Belgium have done a beautiful job in integrating those with mental illness into the society, so they're not ostracized. There's some great examples. I like a lot of what's happening in the UK with the IAPT program to make sure that therapy is going to be of higher quality. And now with 500,000 people each year getting high quality CBT, you can actually see population results in the UK, which is extraordinary. So a lot we can learn from all of those experiments.
Thank you. Another question coming in about the impact of the tech sector in terms of things like equity, transparency, social justice, and labor, and feeling like that impact has been decidedly mixed. And just asking about, as we think about tech companies that are sometimes more oriented towards profit generation, perhaps even monopoly building, is there a reason we should be optimistic about the potential role of tech companies in mental health?
I think it is decidedly mixed, and I think that the future is still really uncertain. I often say we're in Act 1 of a 5-act play, and Act 1 has done a few things. If you look at the mental health tech companies, and by that I don't mean companies building apps. I mean the companies building remote care, like the Gingers, the Lyras. There are a bunch of these, and they've been very successful, mostly with employee-based care strategies. They have increased access remarkably. I mean, they've gone, Lyra has driven their employer market from 3% use of EAPs to 15%, which is pretty good. And they have phenomenally good results to show for that. So I think there's a lot to be excited about, but access is only a piece of this. As I said before, huge issues around engagement and quality. It's not clear to me that just giving people access is going to improve outcomes. It might a little bit, and Lyra would make the case that maybe they do. But I think we have to really think about how do you improve the quality of care, and I don't see that in as many of the tech startups as I'd like. But again, we're in Act 1. I think Act 2 is about quality. Act 3 is going to be more about equity and the democratization of care. So there's a lot that can still happen. We're just at the very beginning.
I think we have time for just one more question. And you had brought up the increased federal funding that occurred as a result of the bill passed in the wake of the Uvalde shooting. And somebody was asking if you could comment on the role of mental health care when it comes to school shootings and what our role is in identifying individuals or social environments susceptible to gun violence.
Yeah, so it's a longer conversation. I mean, it's really dangerous to conflate mass shootings and violence with the issues around mental health. There's no question that many of the people who are involved in violent behavior have untreated mental illness, but obviously most people with mental illness are not untreated, and most of them that either treated or untreated aren't going to be violent unless they're violent against themselves. So it's an extraordinary indictment of who we are as a nation that we can only get federal investment in mental health care after there's a mass shooting, which is really probably irrelevant. I don't know that improving school mental health is going to have much of an impact on these kinds of events. Maybe it will. Certainly, these are young people who might have benefited, but I think if you really care about this issue around violence, you look to, like with suicide, you look to access to means is everything here. You take a public health approach and you figure out not how to improve the number of people in treatment, but how do you make sure that people don't have access to means, and that's the way to bring down suicide as well as homicide.
Yeah. Well, that's all the time we have for questions, but just wanted to say thank you so much for coming to give this talk to us. And
Yeah, my pleasure. I'm glad we could do this, and good luck to all those who are just starting this year academically. Take care.
thank you.
Yeah, bye-bye.